Honored to have with us Dr. Balakrishnan Valliyot, Professor of Medicine, Government Medical College, Kannur, and Dr. R. Rajapaul, Senior Consultant Physician, Diabetic Care Center, Nagarkovil.
So good morning to all. It's really a honor and pleasure for me to chair a session by Professor Rakesh Sahay, and who is an eminent speaker, well-known and a writer. And he was the professor and head of the department of the famous endocrinology center at Osmania Medical College and Osmania General Hospital. And he was been, I heard his talk in several occasions, and he always come to with a newer and very interesting topic. Today he will be discussing us on the fasting in range and the focus on basal insulin. When innumerable number, many number of newer basal insulins coming in the market, it makes us what to choose, how to choose, and what is actually whether we should focus more on the fasting blood sugar or it should be that. So there are many things to be learned from sir. So, welcome to you.
Thank you, sir, for the kind words of introduction. And at the outset, let me thank the entire team at JPEF, Dr. Jyotidev and his entire team for inviting me to be here. And I'm very happy to be here and speaking on this topic called of fasting in range. So the idea of this topic is to emphasize the need, because we have been over the years looking at postprandial glucose levels, focusing on that because they correlate very well with the cardiovascular disease, and that's the reason why the focus has been on that also. But what I would like to reiterate today is that how focusing on the fasting brings about benefits in terms of diabetes management. So we are all aware of the fact that we have a huge burden of diabetes today. We have the ICMR INDAB study which was published recently has shown that there are 101 million people with diabetes and an even larger number of people with pre-diabetes, and this is the huge burden that we have to look at and see that we prevent them from developing the various complications. And across the globe we are seeing that the prevalence is increasing, particularly in the Southeast Asian region, and we also know that India has accounts for about 1 in 7 of all the people living with diabetes across the globe. And half of them are undiagnosed. So that's the greatest challenge, that we need to screen them and identify diabetes early so that we can effectively manage diabetes and prevent the complications associated with diabetes. Now, if you look at the prevalence of diabetes, we know that the prevalence is around 8 to 10% or 11% as we have data from the ICMR INDAB from across the country. But if you look at the impaired fasting glucose itself, if you look at that, we see that prevalence is also about 11.7%. So, and this is projected to increase to about 12.2%. So these are individuals who have a fasting glucose between 110 to 125, and these are individuals who are at a higher risk of progression to diabetes. Now, if you look at the fasting glucose levels itself and how they correlated with the cardiovascular risk. So if you look at this data from more than 11 lakh people of Korean origin, they looked at their fasting glucose levels and followed them up and looked at the cardiovascular disease mortality and incidence of stroke and various other causes from all-cause mortality. And what is interesting from this study is that there is a J-shaped relationship, as you can see. Fasting glucose of less than 70 have a detrimental effect. I mean, in terms of the cardiovascular risk, they increase. We also know this from the ACCORD study, where very aggressive treatment did lead to increased mortality. And then when you look at the levels rising above 110, you find that there is a significant increase in the risk of cardiovascular disease, all-cause mortality, and cardiovascular deaths. So, in between the range of 70 to 110, we are seeing that is the range which has the lowest risk for cardiovascular events with fasting glucose in that range. So in the range of 110 to 125, which is defined as the IFG, there was an increase of 10 to 20% in the risk of cardiovascular events. And that doubled as the person goes into the range of developing diabetes. So both low glucose levels and impaired fasting glucose should be considered as predictors of risk for stroke and coronary artery disease. As the fasting glucose levels rise beyond 100 milligram per DL, the risk for CVD, ischemic heart disease, myocardial infarction and thrombotic strokes progressively increases, but the risk for hemorrhagic stroke did not increase. Fasting glucose of less than 70 were associated with increased risk of all types of strokes. Now let us look at this elegant meta-analysis of more than 102 prospective studies where they looked at the individual records of diabetes, fasting glucose concentrations, other risk factors in people without initial vascular disease. And this is from the emerging risk factor collaboration study. And if you look at this, this is interesting to see that the hazards ratio for coronary artery disease and ischemic stroke, when you compare it with the baseline fasting glucose levels, what we see is that when you adjust for the other covariates, as we said in the previous study, we saw that there is a increase in risk, but when you adjust for the other covariates, fasting blood glucose concentration was not very linearly associated, not non-linearly associated to the risk of coronary artery disease or ischemic stroke. And for both the events, as we are looking at ischemic strokes or with coronary artery disease, you do not see this linear relationship after adjustment for the other covariates. So diabetes itself confers a twofold excess risk for a wide range of vascular disease independent from other conventional risk factors. In people without diabetes, fasting glucose concentration is modestly and non-linearly associated with the increased risk of vascular disease. And fasting glucose concentrations in the range of 70 to 100 have the lowest risk, as beyond that, as we've seen, the increase in risk happens. Now when we are targeting glucose levels, which should be the target for treatment? So when you're looking at targeting the fasting versus the postprandial glucose levels, we have different agents for targeting different types of different glycemic parameters. If you're looking at the postprandial glucose, we have very elegant agents like the alpha glucosidase inhibitors. The DPP4 inhibitors are also very effective in terms of controlling the postprandial glucose levels. Repaglinide, which is a very short-acting miglutinide analog, miglutinide, that also has an effect predominantly on the postprandial glucose levels. While if you look at SUs, they have an effect on both the fasting and the postprandial glucose levels. And amongst the insulins, you have got basal insulins, the conventional NPH insulin, and then you have the long-acting analogs like starting with Glargine, the first generation basal analog, and then we have the newer generation analogs. Today I'll just focus on Glargine and see how effective it is in terms of improving the glycemic status in individuals where fasting glucose was the target. And when looking at the other agents that can control the fasting glucose, metformin is a good agent, pioglitazone, and the SGLT2 inhibitors also predominantly have an effect on the fasting glucose levels. So what is already known from across the globe is that, when you look at the use of insulin across the globe, we see that the majority of people start with the basal insulin initially. When you start insulin naive patients on insulin, basal insulin is the most popular insulin that is started. Even today in our country also, we say that gradually, while we are more of a premixed country, but a premixed nation where we use more of premixed insulin, but still we see that the use of basal insulin has become quite prominent in our country also, and almost about 30 to 40% of insulin initiations are with basal insulin in our country also. And the various basal insulins that we have, I spoke about NPH, which is the conventional basal insulin. It has a duration of action which is 12 to 16 hours only, and has the disadvantage of having a peak. Whereas if you look at the basal analogs like Glargine or the U100 Glargine or U300 Glargine or Degludec, they have a almost flat action, and they have a prolonged action of going from 24 hours to almost 40 hours with Degludec. So those are the advantages that they provide. They have lower risk of nocturnal hypoglycemia because of the absence of that peak, and because of the longer duration of action, you see that you have a better glycemic efficacy of these insulins. So degree of glucose lowering depends upon the amount of insulin used and the degree of insulin resistance that the individual has. And if you look at the insights from a quantitative survey which was done to look at optimal basal insulin titration in people with type 2 diabetes. This was an online survey done across different nations. It was seen that most of the more than 75% of the healthcare providers reported discussing titration at the initial visit, but most of the patients do not remember this discussion because they are more anxious about how to go about with the insulin, how to initiate the insulin, and that anxiety is very much in the initial visits, and subsequently they forget about the titration, and the HCPs also very often may not be re-emphasizing the need for titration. And so this is important that we need to discuss about titration right from the subsequent visits that the patient comes back for a follow-up, so that they remain at target. So this is an interesting study, which is the Fine Asia study, which was looking at first insulinization with basal insulin in patients with type 2 diabetes in a real-world setting. So the HbA1c at initiation in this study was 10.5. Highest was seen in people from Southeast Asia, and when you look at the fasting glucose levels, the average fasting glucose levels were above 200, and these individuals were randomized to either glargine, NPH or detimir. The data on use of glargine, NPH and insulin detimir was looked at because this was a real world study. They looked at, when you look at that, although initially there was no difference in terms of the baseline HbA1c or the baseline glucose levels, after 6 months of NPH, insulin glargine or detimir, the A1c decreased from the 8 plus, it decreased to 7.7%, and 33.7% reached the HbA1c target of less than 7%. Fasting glucose decreased from 210 which was on the average level at initiation, to 129, and almost 30 once again 1/3 of the patients reached the target of less than 110 fasting glucose levels. So if you look at the predictors of successful outcome in patients who are started with basal insulin, it depends on the baseline HbA1c. The lower the baseline HbA1c, the better the outcomes. Shorter diabetes duration, lower body weight, and older age at time of insulin initiation were all the factors that predict a better response to the use of basal insulin, and with titration and optimization of treatment. So this is important. So out of all that, the baseline HbA1c was the most significant predictor of the outcomes for basal insulin basal insulin with optimal titration. Now another study which is interesting is the treat to target study, which was the randomized addition of glargine versus human NPH insulin to oral therapy in patients with type 2 diabetes. This was a 6-month study. 756 patients who were inadequately controlled with oral agents, 1 or 2 oral agents, were randomized to either receiving bedtime NPH or bedtime glargine. And the outcome measures were the achievement of HbA1c target, the fasting plasma glucose, and the risk of hypoglycemia, nocturnal hypoglycemia particularly. And if you see, because this was a treat to target study, both the arms had similar HbA1c reductions. But at the end of treatment, you can see that the HbA1c and the fasting glucose levels were almost similar. I mean fasting glucose and HbA1c, but if you look at the other outcomes of this study, what we see is that glargine causes significantly less nocturnal hypoglycemia than NPH, with providing the same outcomes. It had lesser risk of hypoglycemia. And that is something which gave us the insights on the need for basal insulin therapy, which is basal insulin analogs, glargine, and then you have the further developments in terms of U300 glargine and degludec. Now, if you look at another systematic analysis of several different studies, which looked at fasting plasma glucose and the titration target. So this is interesting because in one of the groups, what they did was that they were randomized to 3 groups. The first group, the fasting target was less than 90. The second group, the target was 90 to 100, and the third group, the target was above 100, the fasting glucose target. So aiming for a lower fasting plasma glucose target improves the glycemic control without increasing the risk of hypoglycemia was what came out from this study. So if you look carefully at some of the details of this study, what we see is that the age distribution of the patients was similar. They had body weight was also similar. So they were pretty much similar in terms of their characteristics, 8.2 HbA1c at onset, and if you see the fasting glucose levels, because the group 1 was targeted towards a lower fasting glucose, they could achieve a lower fasting glucose levels. But if you look at the HbA1c, if you look at the use of insulin in this group, what we see is that there were significant differences between the fasting plasma glucose targets with relatively higher use of insulin degludec in studies summarized as fasting plasma glucose titrated to 90, and relatively more use of insulin glargine in studies summarized as fasting plasma glucose target of 90 to 100. So this is some minor observations in this study, but essentially what we understand is that by targeting to something between 90 to 100 is where you find the best outcomes in terms of the dosage of insulin requirement, which was lowest with the targeting the fasting plasma glucose to the range of 90 to 100. Lower targets may lead to higher use of insulin and the higher risk of hypoglycemia and so from all this, what we understand is that targeting to a fasting glucose levels of 90 to 100 serves as the best, provides the best outcomes in terms of achieving targets, achieving the HbA1c targets, and also having a low risk of hypoglycemia. And with the lower use of insulin, we tend to achieve a better outcome. So HbA1c target achievement reached so that is the gist from this important study, which looked at what should be the target of the glucose in with the use of these new generation basal insulins. Now, based on this, what we see is that the ADA has clearly highlighted. I mean, over the years we have seen that the focus has been on fixing the fasting first, and that continues to remain as the primary target in managing patients with diabetes, where we are looking at adding basal insulin as the first option, and then looking at the postprandial glucose, where the postprandial glucose levels continue to remain high. There you need to probably add the short acting or the rapid acting analogs, but in majority of the patients we achieve the target with the use of basal insulin along with the oral anti-diabetic medications in patients with type 2 diabetes. So fixing the fasting first remains the goal in managing diabetes, and we have the basal analogs which have stood the test of time. And of the various basal analogs, while we have newer and newer ones developing, we have the longer acting ones like degludec, and the once weekly is also coming up, but glargine still remains as a very important molecule that is able to achieve the target in majority of our patients and serves as a very useful agent in many of our patients. Thank you. With that, I'll conclude, and I'll be happy to take any questions.
Thank you, Dr. Sahay, for your wonderful presentation. You proved your merits and your great legacy, I remember vividly. My question is, how about impaired fasting glucose without increase in postprandial blood sugar? The early stage, do you recommend the same one to combat cardiovascular risk?
Yeah. So I think the important issue that we need to look at, we had one interesting study called which was done with glargine, and that was done with the objective of treating early even people who have got impaired fasting glucose with insulin. And the outcome of that study was that we did not find any improvement in cardiovascular outcomes with the use of insulin glargine in that population. So I think the important point that has to be understood is that we need to address other issues also, like lifestyle factors to combat the weight, because weight is an important issue, and we see that the impaired fasting glucose is associated with people being overweight and having MASLD. So I think addressing these issues are important rather than just using the basal insulin. So I think using basal insulin becomes a very good option in people who have got diabetes, who are having a high fasting glucose levels. In that situation, it serves as a useful option, but not in people with pre-diabetes.
audience, he also shares that cardiovascular risk.
Yeah, cardiovascular risk does goes up in such people, and we should be aware of that, and we should address. And insulin alone does not remain as the tool which we have for reducing this cardiovascular risk. We have to look at the cardiovascular risk in the entire spectrum of factors that are contributing to that.
Thank you. Any questions?
I will ask one more.
The audience.
Sir, majority of, hello sir, I am asking. Here, Racha.
Okay.
Sir, so majority of our patients do not have a CGM facility to monitor the blood sugar, and many of our patients are now willing for a A1C, HbA1c estimation. So how far if you are laying to this without availability of a CGM, and what we should have our strategy to use a basal insulin, and if the HbA1c is increased, maybe a postprandial rise. So can we assess some way which we may be able to help our patients?
I really didn't get your question, but I thought, if I got it right, you're saying that CGM, if you don't have a CGM available,
Yes, sir.
and you have fasting, you have a
A1C.
HbA1c, A1c is
Sir,
high, and what do you need to address? So what we generally understand from the A1c data is that when you have very high A1c levels, it is the fasting which is the major contributor. But at lower HbA1c levels, we have postprandial glucose levels contributing, but even fasting also contributes in that. We have recent data from the Asian population particularly showing that fasting glucose also is important in that subgroup of patients. So it's important that we do the point of care blood glucose testing at different points of time. We educate patients to do the home glucose monitoring and maintain proper records if they're not able to do a CGM. CGM would help us certainly, but if they're not able to do that, even a glucose records would help us in understanding how we need to address this this aspect. Yeah. Yeah, Glargine 300 in practice has the advantage of Glargine 300 is that it has a lower risk of nocturnal hypoglycemia as compared to Glargine U100. Which is certainly much lower than NPH, but Glargine U100 also in some situations does cause some amount of nocturnal hypoglycemia that can be overcome with U300, and then you tend to have a better glycemic control in people where the effect of Glargine goes off at say 24 hours. What we see is that we tend to see some of our patients having a higher glucose levels in the evenings. The evening rise is seen in some of the patients who are on Glargine. So here, what the reason is that the effect of Glargine wears off at about 20 hours. To the 20 to 24 hour action is not very good at that point of time. The effect may be going off. In such individuals, Glargine U300 has that benefit. Those who are having nocturnal hypoglycemia, it has that benefit. So these are the advantages that U300 has over U100. Yeah. Well, there's not much of a difference in terms of choosing between U300 and Degludec, but there could be individuals who have who probably have a little variability with any of these two preparations of Glargine, where Degludec may because of its longer action, it may have that advantage. But I think otherwise U300 and Degludec are very much similar, have many similarities.
Okay, if no more questions, we will wind up. Thank you, sir, for very excellent talk on this particular topic. Thank you all the participants. Okay.